the line on this song is, it's so funny that we don't talk anymore. Not the case here. Not on my shift, at least. 9:41, about a quarter till 10 o'clock in the morning. A feature that we've enjoyed over the past, I don't know how many months it's been, 6 or 7 months maybe. But I've enjoyed the relationship that we have had with the GRMC, your healthcare partner, where patients are partners. And I want to welcome into the studio, Cabrera Plinske is here in the flesh. Good morning, Eric. How are you?
Good morning, Patty.
He's the numbers guy and vice president of corporate affairs. And then, I don't even know what title you are. I mean, I know you're a doctor, Felix Cabrera, but it's interesting that every time I talk to you, you seem to advance higher up the scale than the last time I saw you.
Good morning, Patty.
Good morning. How are you?
Good.
You want to go ahead and tell everybody what your new title is?
I am currently now serving as the Chief Medical Officer for GRMC.
Yeah, and here you thought you were just going to graduate from med school, just come here and just treat people, live a bebop your own life, and they put you in charge of everything now. Is that a daunting task for a doctor to go into that other part of the field? Yeah,
it definitely stretches your imagination in some sorts, and it challenges you in ways that you just never thought you'd be in. And so, the benefit is that I've actually served in the past as the Associate Medical Director for Guam Memorial Hospital, right. Helping out Dr. Lizama at the time. And then actually up until our opening at GRMC, I actually served as the Deputy Chief Medical Officer. And that was, for mainly the opening part. But as soon as we opened, I jumped back into the trenches and was purely clinical at that point. And then as the time rolled, it just seemed more and more like the time that was appropriate for me to step back into a more administrative role, but still keeping some clinical time as well. Yeah.
Well, I guess you opened the door to the subject. I mean, that is actually probably a subject that's obvious to have with GRMC, considering what we're looking at and the plight of the Guam Memorial Hospital. Mm-hmm. I'm pretty sure that you never would have wanted to see yourself in some public hearing in front of lawmakers at the legislature trying to defend the Guam Memorial Hospital the way that it is. They are trying to defend it. I mean, it's a full-blown fight is what it is for the money. And having been there in that position.
Well, on first thought, yes, I wouldn't necessarily want to be in that position. But if you really ask me what I would do, even in this position, I would still stand there and fight for Guam Memorial Hospital, even in my current position. And that's because it's just painfully obvious how much this whole region needs both hospitals and Navy Hospital as well. And that even with GRMC having almost all of its beds open, we are still on this island short about 170 beds, 70 beds to really match what's the global standard in terms of population and number of beds needed.
And it's interesting, Eric, from your perspective, looking at this, I'm pretty sure that you watch with great intent just to see how this is all being handled. GMH is a business, really, just as GRMC is a business. And they've been having a really hard time trying to equalize between surviving and expanding in order to survive and generate new revenue. That must be of great interest to you.
Well, of course, Patty, the challenge that GMH has, and we certainly offer any help we can from GRMC. Particularly, their challenge has been that Medicare, Medicaid, MIP reimbursement rate they're getting under what's called TEFRA, from the federal government, and it clearly is reimbursing them less than their costs. But they've had the challenge of trying to get that rectified, what they call rebasing, and it's been just a real barrier wall for them. So in the meantime, they're trying to find a way to cover that gap, and that is where they're reaching out to the government, trying to seek a, line item budget from the government to cover those shortfalls so that they can serve the patient population that they have.
And speaking of, are you worried about the impact of this bill that was signed into law about the choices for health insurance and the numbers of people that will be taken away from GRMC and other clinics because they're choosing one?
Well, we certainly will be if they don't add a clause or reintroduce, shall I say, a bill. I believe it was 21-34. Speaker Cruz previously connected that bill to the exclusive bid contract bill, which would require that all private hospitals or all hospitals on Guam would need to be in the network of any bidding health plan. So that, what makes a hospital different from primary care is that we have an emergency room. And let's face it, GRMC is sitting at the base of where 70% of the population of Guam lives. And you get transported in a general sense by an ambulance to the closest hospital. But even from, your own family, yourself, or friends, someone needs to get some emergency care, they don't, start thinking about, I'm having a heart attack, or my
how am I going to afford this?
Let's drive further. So that's why it's important to protect the patient, first to give them access, to the care they need, and two, to not place the financial burden on the patient. So that's the biggest thing that we're pushing for. If the government decides a single, exclusive contract works financially for them, better, then we can support that as long as we're included in the network of any plan that bids.
Yeah. But the specialty medical care, these sort of patient services that are available over at GRMC, obviously makes the place far more attractive. In your capacity now, Dr. Felix, in your capacity as a CMO, are you also looking to expand into more services, knowing that GMH is really far behind the scale of being able to do that right at the moment? Well,
I think what I feel is more fair is that the conversation be we should talk about the subspecialists that we have and the care that they provide. But I think what's even more important for the whole population is to really understand the backbone of what we do. And the backbone of what we do is quality hospital care. And that includes, your typical internal medicine, typical surgery, typical emergency room services. Those are the backbones. And really the subspecialists are just our fingers of that extension. Now, that being said, I think it's really important that the public really understands that we have exactly the same goals as GMH, in that we are here to serve the people, and we are not here to limit access. We are not here to drive up costs. In fact, cost containment is a big part of it's one of our three goals is cost containment, quality access, and quality in general. When a patient shows up at an emergency room, and if they're in need of emergency services, of course we follow federal law, the EMTALA law. We stabilize them, and we treat them, and we don't transfer them. That conversation needs to stop.
Clarify that, because there is a rumor that
needs to stop.
Okay, because I think that has always been the part of the conversation. There was an agreement already made that you guys were all going to work together, and you were working with the fire department. The closest hospital with an emergency is going to receive that patient regardless of their ability to pay.
And the bottom line is that these patients are, regardless of their payer status, they need the care, and a lot of times we're the only hospital that can provide them this type of care. And so to think of transferring them is just, it's not even in our view. And so we admit them, we take care of them sometimes for months in the ICU. Mm-hmm. All without the ability to pay.
Patti, let's jump into a little bit of a clarification. There are some instances where, for instance, as you know, we have one health plan that hasn't placed us in their network. So, if a patient comes into our hospital, like we said, closest hospital, they're in an emergency setting, they get admitted due to the severity of their condition, but they're with the health plan and won't put us in network, and they're asking, to be transferred because they know that the financial burden is now facing them squarely, and so they ask. So we are going to try to help. Now, the challenge is a lot of times GMH, even upon that request, if they're asking to be transferred there, since that GMH is in their network, a lot of times they don't have a bed available either, so they may be still stuck with us, and we'll keep providing that care. But there are times like that, where we are going to try to help make the transfer. That's for the benefit of the patient. There is also another instance possibly where GMH may have a specialist that we don't have. In the case of pediatric intensive care, they have a pediatric intensivist, I believe, and we don't currently. So it makes more sense in that particular scenario for us to stabilize, transfer to GMH, where they have that specialist, and the vice versa for GMH. If they have a cardiac patient or a stroke patient, they'll likely transfer to us. We have the care that we can provide.
Yeah, and it will. The key word here is stabilization, because once you stabilize the patient, decisions can be made about the rest of their care. Mm-hmm. And clearly, a patient although would love, the fine trappings that are offered by GRMC, can't expect that they are going to be wanting to stay there if they know that they can't pay the bill, if their insurance company doesn't cover it. Why would you want to? That's what you're saying. I mean, it's up to the patient to determine. At some point, the reality is, my insurance company isn't going to cover this. I'm here on just wing and a prayer and good graces, but I am well enough to be transferred to a facility that does honor my insurance.
Right, but sometimes, Patty, the patient, they're not thinking about what is this possible bill going to end up being. They're just thinking, where can I save my life, or where can I save my life? And in some, cases like stroke and GRMC is where it can be done best on the island at the moment, because we have the resources to do it. So, that's sometimes they stay even though they know that the health plan they're with, but they even incur a bigger financial burden.
I completely agree with that. This is why we put on headphones. Al's got something to ask, if you don't mind.
Sure.
Al, go ahead. This is your volume right here.
I'm good. I can.
Okay, go ahead. Al, say hello to Eric and to
hi,
Dr.
Felix. I just wanted to address your comment when you were asking the question or raising the issue about there is some perception in the community that there's horse trading among the ambulance deliveries and they don't want to take them to here or there. That may have been the case when the hospital first opened, just because the hospital is scrambling around and trying to get its feet to the ground and get together. And, maybe some of those issues might have been there then. That is absolutely not the case any longer. And one of the big issues about that is you raised GFC on that. And GFC is very, very heavily involved with this whole ambulance thing. So the EMS Commission and the Commission, it's actually one of the main topics of discussion now in the Commission as to how ambulance functions work for EMS. And so the GFC is instituting and implementing a diversion policy, and the diversion policy is really what would make an ambulance have to switch from one hospital to another. Quite frankly, right now, the way the ambulances are set up, it's geographic on Guam. So there's northern, there's southern, and there's central. And so the ambulance service is trying to work it out with that geographic perspective. And Naval Hospital fits into the equation, too, for real diehard emergencies, and they become part of the network. So in terms of transferring patients from here to there for dubious or reasons that don't make sense, that's going to not be the case any longer, because the way it's working out with diversion, and this commission group involves both GRMC and GMH physicians from the ER. And there's a very good understanding now with how the diversions happen and why they should happen. And so we're very hopeful that we can reach a point in the island where it's going to be like any other place in the U.S., urban settings with multiple hospitals and ambulances. The network works it out that way. I just wanted to make that comment.
I'm glad you did, Al. Thanks so much for that. I appreciate that. It is a point of clarification because, like you said, I mean, there are rumors out there that you're dumping patients at the front door of GMH. And I've seen a lot. I've seen it quite a bit. And I don't know if they take the shot. Is it seasonal and every once in a while they need to bring it up? But
so here. I'm going to offer a very clear example of how that is definitely not the case. So right now we're in the middle of launching a very strong campaign on stroke awareness amongst the community. And part of that awareness is making sure that, because we have a finite window when you can actually intervene that may not only save their life but may save them from permanent disability. And right now, GRMC is the only hospital that offers that service 24/7. So it doesn't matter where you are on the island. You can be in Malolo and have stroke symptoms, and if an ambulance picks you up there, you come straight to GRMC because time is brain, and I don't care what I don't want to know what your insurance status is or anything. You still come. We will take you regardless, and because in the end that's the right thing to do.
I did talk to one of the physicians, your stroke specialist. I can't remember.
Dr. Shea?
Yes. He was in here, and that was the case. There was a case up at GMH where they sent somebody to GRMC after that they called him,
Yes.
on his phone. Remember
Absolutely.
that? Yeah.
And so you'll be hearing more about that during the
Okay.
month of March. But then goes beyond. This is where my favorite word in Guam Regional Medical City is the regional part, and that we're looking at potentially even extending the service as far north as Saipan. If a patient presents there with stroke-like symptoms, how can we emergently get them here within that time frame? We have approximately 10 to 12 hours to intervene, and that's plenty of time to get them here. And so ideally it's within 4 hours, but there can be an extension.
It has to be sort of they have to be medevac ready.
Exactly. And so there's been conversations that we've had. There's been both legislatures from both the Guam and CNMI have already started this conversation, and as well as starting the conversation with the military and see if they can help us in certain circumstances, and trying to define that is where the challenge is going to be.
Well, I do appreciate you guys coming. We have like 3 minutes to finish out the show. I appreciate the time that you're taking. Of course, we can continue this conversation maybe at another time when you're less busy, perhaps. But congratulations on your new position.
Thank you.
Appreciate that.
I hope to serve the people well.
Your healthcare partner, GRMC, where patients are partners.
Healthcare Partners, Tuesdays on Mornings with Patti. Hear the doctors, nurses, and other specialists at GRMC talk about the healthcare issues important to you and what GRMC can do to take care of you and your loved ones. They'll answer your questions and discuss the latest developments in the medical fields they specialize in. Keep it tuned to K-57 on Tuesday mornings at 10:35 to hear your healthcare partners on Mornings with Patti.